Good afternoon and good morning to those of you joining us from other parts of the country. My name is Patty Hyde, and I'm the Director of Clinical and Regulatory Affairs for the Home Care Association of Florida. And I'd like to thank you for attending this event that is being offered in partnership with the Home Care Associations from the great states of Arizona, Nebraska, and Massachusetts. Before we begin, we'll go through the usual housekeeping items. First, we will be recording today's webinar, so if you'd like to recommend this program to one of your colleagues, we always appreciate that. It will be available for purchase in the near future through the association you registered through, and also on our e-learning website at www.homecarelearn.com. Handouts were contained in the login instruction email you received from your association, but in case you cannot locate those handouts right now, just know that you can download them from your GoToWebinar console located under the heading Handouts. Participant phone lines have been muted and will continue to be muted during the presentation to help minimize background noise. However, for those of you that are listening in through the phone line only and are not logged in online, we ask that you please mute your phones on your end using your own phone's muting feature. So please take a moment now to mute your phones and help us avoid any disruptions during the presentation. Time has been scheduled to allow for questions and answers at the end of today's presentation, so we encourage you to type your questions as you think of them during the presentation in the question box area of your GoToMeeting console. If you don't see this area on your screen, just know that you can access this feature from the menu that's at the top of your screen. You want to look for the orange box with the white arrow, which will expand and collapse the console. We'll be able to see the questions and we'll compile them throughout the presentation, and we'll read them aloud for our presenters to respond to them verbally for everyone's benefit once the session's open for questions. And now with those announcements out of the way, I'm going to go ahead and start the recording. And now I would like to officially welcome you to today's presentation on value-based purchasing score improvement. This is session 2 of 6, which will focus on bed transfers, bathing, and ambulation. And it's my pleasure to introduce our speaker for today. Melinda Gabori is co-founder and CEO of Healthcare Provider Solutions. Melinda and Mark Cannon founded the company in April of 2001 to provide financial, reimbursement, billing, and clinical consulting to the home care and hospice industries. Melinda has over 19 years of experience in Medicare home health reimbursement and has remained on the cutting edge of Medicare PPS since the regulation's inception. She has helped her clients bridge the gap between clinical and financial issues and has been a seminar and webcast presenter for 20-plus state home care associations. She's also the author of the Home Health Pocket Guide to Oasis C. And with that, Melinda, I'd like to welcome you and turn things over to you.
Thanks so much, Patty. Welcome to today's session where we're going to primarily focus on understanding how we can show improvement in bed transferring, bathing, and ambulation. Before we get into the details of those three, I just want to emphasize how extremely important it is that your clinicians understand, or you as clinicians, which I'm sure there are many on the phone, how dramatically important Oasis C2 is and the impact that it has on pretty much every facet of home health. As you can see on the screen, it is the driver for the HHRG and HIPS code reimbursement for your patients. So basically, without a completed Oasis, start of care, or recert, we don't get reimbursement of any kind. And so it's the very beginning of the reimbursement process. Of course, Oasis transmission and us making sure that we are transmitting quality data is a driver for whether or not you're going to receive a 2% deduction in your annual rates. Majority of agencies are not going to have an issue there because of the fact that that 2% is based on the fact that if you are transmitting all Oasis as required that you complete, you're going to be in that 80 to 90% range. Reimbursement for non-routine supplies, again, without an Oasis completed, there is no non-routine supply reimbursement. So we need to make sure that, again, our clinicians understand that the supplies are not reimbursed based just on the supplies that we provide or the cost to us, but it is based on specific questions on the Oasis document. If your Oasis is not transmitted, your start of care specifically or recertification Oasis is not transmitted to the federal database prior to billing your final claims effective April 3rd of 2017, you won't be getting paid for that 60-day episode at all. Of course, your state surveyors or accreditation bodies that come in and do your certification surveys are looking at OASIS documentation. They're looking at your reports that come out of CASPR to determine specific focus of your surveys, and of course, in addition to other things. Home Health Compare is driven by OASIS. Quality of patient care star ratings are driven by OASIS. And of course, when you get an ADR, a recovery audit, or a ZPIC review, you don't send the OASIS, you're pretty much denied. And of course, medical review in the process of reviewing those charts is driven primarily by the documentation found on those OASIS documents. We're here today, of course, specifically about the scores that we have been receiving and will continue to receive in the value-based purchasing pilot. And we're going to talk again about those 3 specific items in a moment. And of course, for those of you in 5 states, pre-claim review is barking on the doorstep of some of you while it's already active in the state of Illinois. And of course, one of the primary things that they are looking for in the review of those pre-claim edits is your OASIS C2 documentation. This screen, which is on page 2, if you're looking at the printed PDF file, if you are just looking at the printed PDF file, it's going to be a little strainful for your eyes. But on the screen, if you're on the webinar portion, this is an excerpt from a project that I did for the Florida Home Care Association with some of their participants. We had 71 provider numbers actually send us data. And you see on the screen an excerpt from that only shows 10 providers. And the color coding, if you're looking at the colors, the pink basically is for any score that fell below the average of all 71 agencies in that specific measure. The yellow ones, of course, are 0 scores, so they didn't get an achievement score or a improvement score. And then the blue ones with the asterisk mean there was not enough OASIS or enough patient satisfaction surveys turned in to actually calculate a score for those. And then the green ones at the bottom are basically showing agencies that had less than the average total TPS score, again, for just this group of 71 agencies that sent in their data. And so it shows you the average in the far right-hand column, the average of the 71 agencies put in, the average scores, TPS scores, and this was through the first 6 months of 2016 based on the October 2016 reports. So I wanted to show you this just to show you if you're looking at your own reports and giving you some idea of what other people might be doing. Of course, this is the state of Florida, but it might also, if you're in other states, help give you some comparisons there. And so because of some of the scores that we did see throughout this analysis and discussions with participants in the HCAF Winter Conference, we decided that with those participants, of course, that these lunch and learn sessions, that's why we're doing them at the time we are, we could hopefully have clinical staff sitting around the table, field staff that weren't able to attend that conference to get some more detailed education about how their responses on the OASIS document affect all of this. And that is really why we are here today. So this next screen just gives you a checkoff list of the items that are included in value-based purchasing, Home Health Compare, and the 5-star rating. Obviously, there are more items that you see listed on the screen, more than you see listed on the screen that are included in Home Health Compare, but I wanted to make sure we at least fit in the ones that are value-based purchasing, Home Health Compare, and the 5-star rating. And as I've already shown you, that first page, the list of items that are also included in the HHRG calculation. The ones that are in red at the bottom are ones that were removed from value-based purchasing in the 2017 final regulation, and the 3 you see at the top in green are the 3 that we are going to discuss in further detail today. These are the patient satisfaction scores. In the next 2 webinars in this series, I will be discussing improvement in the home health CAP scores, so your home health patient satisfaction scores leading to that 5-star rating, as well as improvement in your value-based purchasing scores in those patient satisfaction categories. These are the items that are specifically linked to calculating your HIPS code. So each of the items that you see on the screen, the M items, some of them related to value-based purchasing, some are not. The ones that are lined out in red are ones that you no longer get points for in the calculation of the HIPS code. Those were the clinical domain. And then you see the functional domain here. Again, this is in the calculation of your HIPS code for the claim. You can see the 3 items that we're specifically going to discuss today, bathing, transferring, and ambulation, are all included in those. So I hope I've driven home the point already that it is extremely important that we understand fully that when we are completing this document, it's not just a document to be completed or another piece of paper or another thing that we have to document on to protect the agency or to help with medical review, but it is driving pretty much everything. It is driving our initial reimbursement, it's driving our scores in all of these different pilots and programs, and of course affects our reimbursement on the back end as well. So hopefully I've driven that point home, and you will share with any staff that are not here today the extreme importance of that. So before we get into the details of each of these items, I want to talk a little bit about how the outcome is actually calculated. And so for each of the items that an outcome is calculated for, and of course it's not just these 3, but for all of the items that we're going to be sharing with you over the course of these webinars, the ones that are not patient satisfaction survey driven, but the ones that are OASIS driven, have specific items that may or may not affect that outcome other than the actual M item itself. So when we talk about transferring, bathing, and ambulation, M 1830, 1850, and 1860, those today, all 3 of those, as you know, are found in the ADL section of the OASIS. Each one of those also carries with it exceptions or exclusions is the exact word I should be using. And if those exclusions apply, then the calculation of an outcome for that particular item would not occur. And so these items are calculated excuse me, using the start of care OASIS, a quality episode from the start of care to transfer or discharge, depending on the item. And the exclusions specifically for these 3 items, all 3 of them, while ambulation is the one that's being mentioned on this screen, this applies to all 3 of these items. So if at the start of care, ambulation and locomotion is answered 0, that means that your patient is basically independent, and it would not be included in the calculations of outcomes. Also, another item that you need to make sure your clinicians understand is if you're answering the ambulation question 0, you are basically leaving no room whatsoever for there to be support for that patient to be homebound. Ambulation answered 0 basically means the patient can go up and down stairs with or without railings, needs no human assistance or assistive device. And if that be the case, it is extremely difficult to be able to document that that patient's homebound. Now, keeping in mind, of course, that if you have a psychiatric program and you are documenting the psychiatric issues that causes that patient to be homebound, then that's a different story. Other than psychiatric patients, however, answering 1860 is basically saying your patient's not homebound. But in addition to that, if you are answering at 0, there will not be a calculation of an outcome for that item. The second bullet says the value recorded of OASIS item 1700 or M1700, cognitive functioning, if that equals a 4, indicating that the patient was totally dependent due to disturbances such as constant disorientation, coma, persistent vegetative state, or delirium, an outcome for ambulation will not be calculated. Also for M1710, when is the patient confused, and 1720, when is the patient anxious, if both of those items or either of those items are marked not applicable on the start of care or resumption of care, indicating that the patient is non-responsive, then a calculation for an ambulation outcome would not be made either. So ambulation answered 0, cognitive functioning answered 4, 1710, 1720 answered not applicable, meaning they're non-responsive. Then you will not get a calculation of an outcome for ambulation, transferring, or bathing. All three of these apply to all three of those outcome calculations. Also, if the patient did not have a discharge assessment because the episode of care ended in a transfer to inpatient facility or a death at home, there will also not be a calculation. So if your OASIS at the end of this patient's episode of care is a transfer to inpatient facility or it's a death at home, there will not be an ambulation outcome calculated. And that's because you don't answer the ambulation question on that transfer to inpatient facility or death at home assessment. So there are exceptions, and there are some that have thought or believe that the simple M1860 and the scoring for it is what would cause there to be a score for ambulation, same for transferring and bathing. But as you can see, there are other items that actually go into that mix. So wanted to make sure we were clear on that. This next screen titled Intent of ADLs is some specific, or some general guidance, I should say, some general guidance but specific to ADLs, or the ADL section of the OASIS documentation. So this identifies the patient's ability to safely transfer. This one came specifically with the transfer question, but it would also say for ambulation, ability to safely ambulate, and then bathing is the same thing. So this one is specific to transferring from the bed to the chair, or positioning self in bed if bed fast. And then the intent portion is applicable word for word to all three of these items. The intent of this item is to identify the patient's ability, not necessarily their actual performance. Willingness and adherence are not the focus of these items. These items address the patient's ability to safely transfer given the current physical, mental, emotional, and cognitive status, activities permitted, and environment. The patient must be viewed from a holistic perspective in assessing their ability to perform ADLs. Ability can be temporarily or permanently limited by physical impairments, for example, limited range of motion or impaired balance. Also, it could be affected by emotional, cognitive, or behavioral impairments, or sensory impairments is also included there, and then environmental barriers, including narrow doorways, staircases, etc. So, again, while I copied this one straight out of the transfer question, this is word for word what is also listed with the ambulation question, the bathing question, all the ADL questions, and the instruction trying to get us all to understand that we have to assess the patient's ability on each of these items, not necessarily what they're currently practicing. The example that I use for this quite often, my grandparents had my aunts and uncles had my grandparents a new bathroom installed in their home when I was quite young, and the shower in that bathroom was never used. They had never had one before, and they had been basically taking sponge baths, their entire life, etc., and had never taken a shower and never did. And so that shower was basically used as a storage closet. And so my point in saying that is, up until the last few years, or year, I guess, probably, of her life, up until the day he died, they could have used, they had the ability to use that shower, but they simply did not do it and weren't going to do it. So the point in that is they were not willing to do it, weren't going to do it, didn't do it, but that did not mean they did not have the physical ability to do it. And so that's where we have to draw the line. Now, I get with each of these items, there's some circumstances that may tweak that question a little bit, which drives me crazy, and we're going to talk about that in a moment. But for the general overall purpose of these ADL items, we are scoring based on the patient's ability, not their willingness or compliance. Okay, so moving on to the first item, we're going to talk first today about transferring. The item reads their current ability to move safely from bed to chair, or their ability to turn and position self in bed if the patient is bedfast. So you see all of the options here on the screen. 0 meaning they're totally independent in transferring, 5 meaning that they are bedfast or unable to transfer and unable to turn or position self in bed. So one of the things that I want to say up front before we even get into these items is that I am a 100% advocate of clinicians being educated in reading these responses from the bottom up. And so we are looking at a patient's transferring ability. We're going to start with number 5 and say, okay, the patient's not bedfast, so we're going to go to the next one. The patient's not bedfast, so we're going to go to number 3. Unable to transfer self and is unable to bear weight or pivot when transferred by another person. So if they're unable to bear weight or pivot or transfer themselves at all, then we're going to go to number 2 if that's not true and go from there. So I think you see the point here. In some of these other items, it may be even more apparent of us getting the right answer, especially in ambulation. But if we start from the top, yes, they're not totally independent. We go to the next one, and, what is minimal, human assistance or with the use of an assistive device? If we go to the next one, oh, yeah, okay, they're able to bear weight and pivot, but cannot technically do this by themselves. And sometimes the only key factor there is they cannot completely do it by themselves safely. Prior to OASIS C1, the word safety or safely was not even in the actual wording of these OASIS items. It was in the instruction or the intent of the ADLs at the heading or the beginning of the ADL section. Now it is actually in the wording of the item, but I fear that our clinicians still are not truly assessing the patient's ability and applying the safety factor. While they may be doing this themselves on a daily or routine basis, that does not mean they are safe doing it. And so we really need to take a hardcore stance with our clinicians in making sure that they get the safety factor. Again, just because no one lives with them and they may be doing whatever it is that we're assessing on a daily basis, again, doesn't mean they're safe in doing that. And that helps justify, of course, any treatment that we may need to be providing to the patient. So the next screen is an excerpt of the instructions from the OASIS C2 manuals that talk about some of the strategies and response options. For most patients, the transfer between the bed and the chair will include transferring from a supine position in bed to a sitting position at the bedside, then some type of standing pivot, or sliding to a chair and back into bed from the chair or seated position. So a couple of key things here. As you'll see in some of the follow-up in just a minute, technically if there's not a chair in the patient's bedroom, the Q&A has given us instruction that we are to have the patient transfer to whatever normal sitting area they would go to sit in, even if that means it's a chair in the kitchen or a chair in the living area. The other thing I want to make sure we hear is it says at the end of that first bullet, and back into bed from the chair or seating position or surface. So you want to make sure that you're assessing the patient's transferring ability, not just from the bed to that chair, oh, I made it, but back again as well. And so it may be that their bed is too high, and they're basically kind of sliding out of it and getting to the chair, but then when it goes back to getting back in bed, it's not such a easy task. So make sure that your clinicians are assessing them in both directions, both from the bed to a chair, from the chair back to the bed. And that next bullet is the one that talks about there being a chair in that bedroom. The next screen gets into the items, the response items specifically. In response 1, minimal human assistance could include a combination of verbal cueing, environmental setup, or actual hands-on assistance. And so verbal cueing is an item that I think is very underused, or I should say under-considered, meaning while verbal cueing may be occurring with the patients, and not just in transferring, but in other ADLs as well, we may not fully understand the significance of that being assistance. And so make sure your clinicians truly get that the verbal cueing portion of each of these items is extremely important, and verbal cueing should be included in their assessment, and knowing that, of course, the patient needs that assistance. In order for the assistance to be considered minimal, it should mean that the individual assisting the patient is contributing less than 25% of the total effort. So I get that it's still a little, gray in a sense of what 25%, of the total effort really is in transferring this patient, but at least you have some guidance in the sense of having 25% and not being just left with nothing. If the patient transfers either with minimal assistance but not a device, or with the use of a device but no human assistance, you're still going to enter 1. The patient requires both minimal assistance from a human and assistive device to transfer safely, then the patient is going to be a 2. So make sure that your clinicians get that. If it's one or the other, they're going to be a 1. If they need human assistance and a device, they're going to be a 2. If the patient can bear weight and pivot but requires more than minimal assistance to transfer, then we're going to be a 2 as well. Patient must be able to bear weight and pivot for number 2 to apply. So that's also another huge key factor. While they may be able to pivot but can't bear weight, including that there are currently orders for the patient to not bear weight, then they would be a 3, not a 2. If the patient is bedfast, of course, the patient is going to be a 4 or a 5, depending on whether or not they are able to reposition themselves in the bed. The next thing I want to talk about today is the newest item that's added to the OASIS. And while it has not been, or while it is not currently an outcome measure, and it is not currently a measure on value-based purchasing, I feel that this newest OASIS C2 item is extremely important and does coincide directly with transferring, and the consistency between those two responses could cause issues if there is an inconsistency. Meaning, if you answer that the patient can transfer, but then in mobility, the next item we're going to look at, GG0170C, you say here things about the patient that would make us believe that they weren't as good at transferring as you have said, or they're not as bad at transferring as you may have said. there could definitely be medical review implications. Now, we're not going to spend a ton of time here, but I do want to take you through this newest item, and I think obviously you see and very well know if you're completing OASIS on a day-to-day basis, the correlation, or at least partial correlation between this mobility item and the transferring item we just looked at. So the one other thing I do want to point out, and when I said a few minutes ago, with each of these M items, I would encourage you to teach your clinicians to read from the bottom up. That is obviously just the opposite in this GG item, because the GG item has already been flipped. And I think that's probably for a reason. I don't know how many people know this, but this GG item came straight from a skilled nursing facility documentation. And so the skilled nursing facility documents most likely already have them reversed, so that they're looking, or they're not reversed in the sense of independent versus dependent. So those items are still the same, but the numbers are backwards. So really what I was getting to say is it doesn't apply. So independent is still at the top of this one, can be really confusing, even especially if you're used to doing the M items, of course. But if you look at the very bottom, dependent, meaning the person helping this person is going to provide 100% of the effort, then yes, it's going to be at the bottom still, but it's going to be a 1 versus a 6. So you want to make sure your clinicians see the difference in that numbering, but you can see that the scale for dependence versus independence is still in the same order that it is on the OASIS. The numbering part is just backwards. So the intent of this item is to identify the patient's ability or need for assistance in moving from lying on their back to sitting on the side of the bed with their feet flat on the floor and no back support. So as you can see, there's a direct correlation in this part of the item in the transferring item, as we've just gone through. With the transferring situation, the patient basically is lying on the bed and has to sit up, turn to sit on the side of the bed, and then transfer to a chair or other sitting place within their home. And so this is definitely a part of that. And obviously, when you're assessing transferring, you can also be assessing this GG mobility item at the same time. There doesn't have to be a unique item or activity, I should say, for each of these individual OASIS C2 items. Many of them you can string together with one activity. So you ask the patient who's lying in bed to go to the bathroom so that you can see them get in and out of the bathtub or shower. So they're lying in the bed, they sit up, they turn to the side, put their feet on the ground, we've got the mobility item. They transfer to a chair. From the chair, they stand, transfer back to the bed, then stand and ambulate to the bathroom, where we would then see if they can get in and out of the bathtub, and also ask them to show you how they get on and off of the toilet. So one string of these ADL items, several of them being answered in one, and obviously while they're in ambulation mode, being able to determine their level of dyspnea and very possibly assessing at that point any pain in that activity. And so I know clinicians can get very frustrated in how they make all of this happen in one visit, but again, stringing together multiple ones, assessment of multiple ones into one simple, I say simple, it may not be a simple activity for the patient, but into one activity will get you several answers. So something definitely to think about. So with this GG item, continuing, mobility while they're lying on the bed, just sitting on the edge of the bed, as we've said already. If they use they can use an assistive device if needed. They can use the assistive device, and then of course whichever option gives you, or whichever response gives you the option of answering that they can do it with an assistive device would be applicable. However, if they need human assistance in moving that device to a spot where they can utilize it, the human assistance factor comes into play. Making sure that you consider safety, of course, in all of these items included in this GG item as well. the items, each of them listed there as you can see. One of the questions I get quite often is this setup or cleanup assistance with a patient that you're simply assessing their ability to rise from lying in the bed, turn and sit on the side of the bed with their feet on the floor. What setup, would there be for that? And so one of the examples that's given in the manuals is a patient where someone has to provide assistance in possibly turning back the bed clothing, the comforter, bedspread, whatever it is, and sheets before the patient can actually perform the mobility activity. That would be considered a part of setup. So someone had to do things for them, and that would be included also if you were having to move a device to a place where they were actually able to participate. If your patient does not attempt this activity, then you're going to mark one of the responses you see on the screen that they refuse to do so. Not applicable means that they were not able to do it before you came into the home, prior to their current illness, injury, or exacerbation, and so it would not be an item that you would need to attempt with them now. If you're not attempting it due to their current medical condition or safety concerns, then you're going to mark 88. So the difference in the two, 88, is if they have a current illness or injury safety issue that you will not attempt it or not allow them to attempt it for that reason. It's 88. You will use 9 if the patient was not able to do this before and there's no reason they'd be able to do it now. Also a part of this GG item is setting a discharge goal. So while you're answering their level of dependence at this point in the second column of that item, you're also telling them or marking which status you anticipate they will be upon discharge from home health. This is another item that could definitely cause issue or conflict in medical review if you're saying as your discharge goal being that the patient will be fully independent in this mobility item, and then your goals for that patient, especially in a therapy plan of care, don't resemble that at all. So something to keep in mind. Then this is a mobility example, which we don't have time to read through today, but you can read through that as you go. And this is number 2, is also an example, those both being straight out of the OASIS C2 guidance manual and help with that GG item. So the next item we're going to talk about today is ambulation. Ambulation is M1860 and has been a platform of controversy ever since it was added to the OASIS for multiple reasons. When it was added to Home Health Compare and we were asked to show improvement in this condition, it was really difficult for many to find a way to even document improvement in this area because of the generalities, I guess I should say, in the item or the response choices that we had at the time. And so with a recent update, OASIS C1, I believe, is when they broke out some of these answers or responses into more than one response, giving us a little bit more wiggle room for improvement. But I'm still convinced, based on seeing some of the outcomes and seeing some individual charts, and I shouldn't say some, multitudes of individual charts that we review on an ongoing basis, still convinced that the clinicians completing these OASIS documents don't fully understand the difference between these items and what all is included in the specific response. So the ambulation question asked their current ability to walk safely, there's that word again, safely, once in a standing position, or use a wheelchair once in a seated position on a variety of surfaces. So as we've already stated, if you mark this item 0, you're saying the patient's able to walk on even or uneven surfaces and negotiate stairs with or without railings, needs no human assistance or assistive device. So even if your patient is walking up and down the stairs independently with a cane, they cannot be a 0. We also have concern with number 1 even being a patient that is homebound, because it says with the use of a one-handed device, for example, cane, single crutch, Hemi walker, able to independently walk on even or uneven surfaces and negotiate stairs with or without railings. So the only difference in 0 and 1 is that your patient is using a one-handed device, but they are still independent. So if your patient can still independently go up and down stairs with or without railings, needs no human assistance or assistive device, even with a cane, I still find it extremely difficult that you are going to be able to support and thoroughly document homebound status. While 0 is pretty much an automatic, patient's not homebound, you may have a little bit of room with 1, but I struggle to find that room for the patient to be homebound. So when we talk about the outcome issue here, getting the patient from a 1 to a 0 would basically be progressing that patient from being independent with a cane to no longer needing the cane. So there is a level of possibility of proof, even from, possibility of improvement, even from a 1 to a 0. But the question again here is the patient even homebound at even a 1? Also, you have to keep in mind, if that patient is walking up and down the stairs in their home with a cane, are they safe in doing so, even though they're currently doing it and doing it all the time? Does that mean that they're safe? If not, you would have to mark them as a 2. So the same issue arises with a 2. A 2 RAIDS requires the use of a two-handed device able to independently walk, a two-handed device to walk alone on a level surface or requires human supervision or assistance to negotiate stairs or steps or uneven surfaces. So making sure your clinicians understand this is an or item. So if the patient is using a one-handed device, but they require human supervision or assistance to negotiate stairs or steps or uneven surfaces, then there's still going to be a 2. We are reading pieces and parts of these responses and not fully absorbing and comprehending the entire intent of each of the responses, and obviously leaving out the safety factor in many cases. Number 3, able to walk only with the supervision or assistance of another person at all times. So even with that patient that has a cane going up and down stairs but is not safe in doing so and truly needs supervision or assistance to be safe, they would be a 2, and then obviously there's room for improvement to get them to a 1 with the one-handed device independent. So there is room for improvement in this item, obviously, and chair fast and bed bound being at the bottom of that list. The only really bad negative thing I have to say about this item in regard to reimbursement is that they have made the point allocations to get to your HIPS code virtually impossible for you to get to a functional 3 or the highest functional level anymore unless your patient truly is chair fast or bed bound. These next couple of screens give you some instructions straight out of the OASIS C2 guidance manual specific to ambulation. Regardless of the need for an assistive device, if the patient requires human assistance to safely ambulate, then you must enter response 2 or 3, depending on whether the assistance is intermittent or continuous. So, as I stated a moment ago, even if they're using a cane, if they're not safe in doing so and truly need assistance to be safe, you're going to answer 3 versus 2. And that pretty much sums up the next 2 bullets as well. On this next 2 page, if the patient does not have a walking device but is clearly not safely walking alone, you're going to enter response 3, that they need supervision or assistance, unless the patient's chair fast, of course, and then they would be answered 4 or 5. The assessment strategies, that's at the bullet at the bottom of this page, says a combined observation and interview approach with the patient or caregiver is helpful in determining the most accurate response for this item. Ask the patient about their ambulation ability, but observe the patient ambulating across the room or to the bathroom, etc. So while many of you are thinking, we already know that, we already know we're supposed to do that, little nightmare story for you very quickly, and then we're going to move on to bathing. My mother, after having open heart surgery, well, yes, it was open heart surgery in a sense. She had to have an aortic valve replaced. She comes home from the hospital. The nurse comes to do her start of care for home care, and she'd never been in home health before, so these people did not know her, and not that it's okay if they had. But anyway, I was out of town when the home health nurse was scheduled to be there. I called her from the hotel that night and asked her if the nurse came. Yes, she was really happy with the nurse, etc. But this is the kicker. That nurse was in my home doing my mother's start of care assessment for 45 minutes, and my mother never left her recliner. She never once asked her to ambulate to the kitchen. She never once asked her to ambulate to the bathroom. She did not even ask her to get up out of the recliner and transfer to her bed and back again. My mother never moved out of her recliner, and she had every ability to do so, but the nurse needed to see what we had to do handicapping-wise, her bathroom. She needed to see the chair that my mother had to roll around in the kitchen in order to cook something to eat or even get something to eat if we weren't home with her. She needed to see all that stuff, and it just simply didn't happen. So while I understand that many of you have heard this stuff over and over again, I hope you are truly applying it, and I hope you can definitely make sure that you are questioning any clinicians that the documentation just doesn't quite make sense with what you may know to be true about a patient, or in some cases what therapists may be coming back with about those patients. The next item is bathing. Bathing reads their current ability to wash their entire body safely. Excludes grooming, washing face, washing hands, and shampooing hair. Now this is the one that really makes me mad. And that is because that question clearly asks the patient's current ability to wash their entire body. And then we get into all the Q&A, and we get into the fact of them not having running water or them not having a working bathtub, etc. So confusion, frustration, absolutely, no doubt about it. And so you need to make sure that you have read through and understand all of those implications and understand that there are limitations to your responses. Again, I am 100% convinced we need to be reading these responses from the bottom up and assessing what the patient's true ability is. And in many cases, when doing that, you're going to wind up with a more true reflective response of where the patient actually is safely performing the activity. So some of the items, or instruction I should say, specific to bathing includes that, of course, it is excluding washing their face and hands and shampooing their hair. Patient's ability may change as the patient's condition improves. So obviously they could be, in this bathing question specifically, could be in great need of help in the bathing process, and of course that may change and should change if we have therapy, and especially in later assessments. If the patient's ability varies over time, enter the response describing the patient's ability more than 50% of the time under consideration. So if they may struggle, really more difficult in the morning when they first get out of bed, having taken their pain medications 2 hours later, they're much more capable of performing safely, then that has to be taken into consideration, and you're to report what is true of the patient greater than 50% of the time. The bathing scale represents the most dependent, as we already know, independent to dependent. Number 3, if the patient requires standby assistance to bathe safely in the tub or shower, requires verbal cueing, there's that verbal cueing again, then enter response 2 or 3, depending on whether it's intermittent or continuous need. The next screen, if the patient's ability to transfer in and out of the tub or shower is the only bathing task requiring human assistance, then you're going to enter response 2. If the patient requires 1, 2, or all 3 of the types of assistance listed in response 2, but not continuous presence of another person, you're going to enter a 2. If they need continuous presence of another person, then you're going to enter number 3. Patient status should not be based on an assumption of their ability, but their actual assessment or performance. Did everybody hear that? The patient status should not be based on an assumption of the patient's ability to perform a task with equipment they don't currently have. It must be with an assessment. So that's what drives me crazy. So if the patient doesn't have a current working tub, shower, etc., then obviously you can't assume their ability. Now, this next one is extremely important to understand, and that is medical restrictions that the patient may have. If they're medically restricted from climbing stairs and their tub or shower is upstairs, then they have to be marked. They currently do not have the ability to perform. That would also include if they can't ambulate currently, et cetera, et cetera. So making sure that all things in place in order to truly assess the patient, not making assumptions. The next page, if the patient does not have a tub or shower, as we all know, as I've already said, we're going to mark 4, 5, or 6. If response 4, the patient must be able to safely and independently bathe outside the tub or shower, including assessing water at the sink or setting up a basin at the bedside, etc. So if they don't have a tub or shower, you don't automatically mark that they're independent in setting up and being able to give themselves a sponge bath, etc. outside the tub or shower. You need to truly assess their ability to do so. Enter number 6, response 6, if the patient is totally unable to participate in bathing at all and requires the assistance of another person. So making sure that we're not automatically marking a 6 just because they don't have the equipment in the form of a tub or shower, but we're assessing their ability outside the tub or shower in selecting response 4 or 5 if applicable. So this last screen just wraps up the things that we've talked about today and makes a few key points. We are to conduct a full comprehensive assessment of the patient, not simply ask questions or conduct an interview. We're to never make assumptions. Obviously, we're not always going to get the right answer in an interview, and obviously we do need to interview the patient and ask questions of the patient. But most importantly, especially for the ADL section, we need to be assessing that patient, observing that patient during assessment, and requesting that they perform the activities that we are to assess. Make sure that each and every Make sure that each and every M item on the OASIS, the clinicians understand the intent and the do's and don'ts of selecting those responses. So safety is one of those big things, and we're not saying the patient's independent if they're not safely independent, and making sure that some of those intricate details listed in some of those response items are adhered to as well. Clinicians that are completing OASIS have to be vested in improvement in our scoring, as well as in our reimbursement, as well as in patient care, of course. We have to be able to justify the reimbursement we are being paid for this patient's care. We have to be able to justify the care that we're providing to these patients. And if we're scoring our patients as basically independent at start of care, then how are we going to justify the care that we're saying we need to provide? In so many cases, in charts that we've reviewed with deficiencies, etc., it is not, in talking with the clinicians, it is not that the patient didn't need the care or that the patient didn't qualify for the care. It's simply we are not documenting toward that need for care. And when our charts are medically reviewed, they start with the OASIS. And if there is no justification for the care that we've provided in the OASIS, then there's basically going to be no justification for the care that we've provided. And if they're going to go with the OASIS documentation in medical review versus other documentation they may find in the notes. That comprehensive assessment and OASIS C2 completion is the core for all medical review, for reimbursement, for outcomes, etc. The last two bullets involve your aides. Your home health aides are some of the most important human beings in the care of your patients. And so when I say involve them, obviously they can't complete OASIS. I get that. But when it comes to the improvement in your patient's condition, while your aides are there for assistance, etc., they can be those alarms that they're calling and telling you that she's having issues with walking without breathing difficulties today. And they can be the ones to tell you that she slipped and fell last night and reporting those things. And they can be the ones to tell you that this patient really needs therapy because I'm struggling desperately to safely assist them in getting in and out of the tub or shower, et cetera, et cetera. So your home health aides are extremely important, obviously, to the care of the patient, but also into driving improvement in the patient. And as we're going to talk about in the next couple of sessions in this series, when we talk about patient satisfaction survey scores, your home health aides are some of the most important individuals ever when it comes to care satisfaction of your patients. And then lastly, communication. We have to communicate to other caregivers within the care team that's caring for patients. We have to communicate, just as I've illustrated, between aides and therapists and aides and nurses. We have to communicate with the patient, but we have to have that interdisciplinary communication and about the patient's care plan and about the improvement in the patient's condition or things that need to be changed. I've read in charts where therapists have documented really high blood pressures on patients and maybe even held some of the treatment for the patient that day because their blood pressure was high, and then find no evidence at all in the chart that that was reported to a physician or a nurse. And the same being true of nurses documenting that the patient fell last night or the patient scratched, had an incident with the bathtub or whatever, and that not be reported, any evidence of it being reported to the therapist or even to the physician. Once again, communication's got to happen, and the most important piece of that communication in improvement and driving improvement is that interdisciplinary communication between your staff, the caregivers of this patient, and the people that hold the answers to that improvement. And last comment I want to make is about the completion of discharge OASIS, which you're going to hear us say probably in every session you hear except the patient satisfaction survey ones. These improvement measures, the outcomes are calculated based on start of care to transfer and discharge depending on the outcome, or resumption of care to discharge. So we have to get ingrained in our clinicians and quality people's minds that the discharge OASIS is as important, if not more important, than the start of care and research and resumption of care OASIS, because of the fact that they totally drive not only medical reimbursement, medical review of your charts, but totally drive the outcome of the improvement of your patients. So we're going to have questions now if there are any to be answered.
Okay, Melinda. So what we're going to do, I'll give everyone a moment to type any last-minute questions. And in the meantime, I just want to remind everyone that an evaluation of today's event will pop up on your computer as you go to exit the event. So please make sure you complete the evaluation. And if you have more than one person listening in at your location, we encourage them to fill out the paper version of the eval form that came with your handouts. And you can send those back to your respective associations, or you can fax them back to HCAF at 850-222-9251. That number again is 850-222-9251. Okay, first question, Melinda asks, if a patient is unwilling to take a shower and they insist on taking a sponge bath, how do you assess the ability for the patient to complete a shower by themselves safely?
Most clinicians are not going to go through the process of actually having the patient take a shower, and I understand that. They are, however, expected to at least assess the patient getting in and out of the shower, and of course being able to acknowledge the factor there with them getting in and out of the shower, etc. I think interview comes in to play a lot with the patient, caregivers, etc., that may be in the home or may be staying with the patient during times when they would bathe, etc., and questions that may go into the play of them actually, having to have someone in there, etc. So there's a little bit of play work. I get that when they totally refuse. I think to take a shower, I'm saying. But I think we have to be able to hopefully get them to at least get in and out of the shower for us, and being able to assess that. I get there's always that tricky patient, and you're going to have to decide within your agency what you do at that point. And if there is, the fear factor, we get that a lot. Patient won't get into the tub or shower because of their fear of falling, and obviously that's a safety issue, a huge safety issue. And so we're going to be moving that patient down the scale of where they would be in the response. You can't force a patient to do things. We get that. But at least asking them and trying to get them to go in and out of the tub or shower, even if they're only going to take a sponge bath, will at least head us down the road of getting that true assessment.
Okay, and the next question deals with transfers. And they ask, does the patient have to bear weight on both lower extremities to be considered a 2, meaning the patient, for example, had a knee replacement on the left knee but bears weight on the right leg during the transfer?
That's a really good question. My thought at this moment, which I will check into just a little bit more, okay, here it is. I've got it right here. It says, able to bear weight refers to the patient's ability to support the majority of his or her body weight through any combination of weight-bearing extremities. So if the patient is able to fully bear weight, their entire body weight, majority is what it says, majority of body weight on that one lower extremity, then it would count as bearing weight.
All right, very good. Thank you, Melinda. And with that, I'm not seeing any further questions. So I'm just going to turn it back over to you for any final thoughts you care to share.
Well, I just want to thank everyone for participating today. Encourage you to participate in the rest of this series, the next 2 again being on patient satisfaction surveys. Make sure your clinicians are educated. They should all have a copy of the OASIS C2 guidance manual if they don't already, so that they can reference things. I just read to you about the ability to bear weight comment straight out of the OASIS C2 guidance manual. So a very good example of when your clinicians may need that. And obviously you can download it electronically, the OASIS C2 guidance manual from the site, and have it on their computers so that they can reference. They don't necessarily have to carry that big thing, printed out. Anyway, education is all I can say, and communication. Thank you all.